9I, T4 syndrome. This is in Modern Manual Therapy of the Vertebral Column. Here in Chapter 50, Examination of the Thoracic Spine. Now here we have thoracic joints and dura mater. Sternocostal joint and costochondral junction lesions contributing to the symptoms should not be forgotten. And those basically run costosternal and costochondral, angle off like so. And look at what the symptoms are. Numbness of the trunk or legs. So any type of numbness anywhere down the trunk or legs. And at a seminar last weekend, a doctor was having a lot of numbness in his feet for several years. And we just went on those with a medium ball tip prod. He said it immediately reduced the numbness by half, which was a great thing for him. Every patient showed some weakness of the legs. Now, that's important because you can get somebody who isn't able to stand, is having trouble walking, can't get out of a wheelchair because of weakness in the legs just by stimulating those points. You'd be surprised at what you can do. Also in athletes, for some reason they've lost strength or endurance in their legs. Stimulate those points. What do you have to lose? I've seen a lot of people come around just by stimulating those points. So now we're going to go on down to T4 syndrome. Now the T4 syndrome does not mean that T4 is the only level involved. There may be one or more levels affected between T2 and T7. So here we have skull cap pain all over the skull. We also have pain from the wrist through the hands, elbows through the hands, shoulders through the hands. And you notice it's bilateral. Well, several months ago I had a female, roughly 20, give or take, and she was complaining about neuropathies and paresthesias in her wrists, hands, ankles, and feet. And so I immediately thought about this, at least for the hands, and we took medium small tip prod and we scraped T2 to 7. And the only one that was active was T4, scraping the spinous tips. We got rid of that, and not only did it get rid of the wrist and hand neuropathies and paresthesias, but also the ankles and feet. So I've added that to my repertoire. So when you have any of that in those areas, always think of that. What do you have to lose? You may be able to do a lot of good for that particular individual. 9J. Okay, here we have the Meridians of Acupuncture, Felix Mann. I encourage you to get all of these texts that we're quoting out of here. That's how I learned, that's how you can learn. So basically we're going to go through here, and the reason that I want you to see this, basically I've kind of marked things here. What in this particular meridian, this is the lung main meridian, what organs are affected. So when somebody comes in and they have a particular organ problem, let's take a shortcut. Go to somebody who's already established it, and you stimulate any of those particular points you see highlighted here. And it also shows the particular other meridians that it interacts with. And here we have lung muscle meridian, okay? So you would stimulate those. Now, these in particular take care of the muscles and the skeleton. So any of the musculoskeletal areas where you see this traced, I would encourage you to just cut these out and make a flip chart of them. If somebody has musculoskeletal areas in these areas, stimulate those particular points and you'll be surprised how many of them clear up just very readily. And here we have the large intestine main meridian, and see where that traces through. For example, if the person has problems in the lips, this would be an area to go to. But look, lungs, diaphragm, large intestine, and you see all the interactions here. Governing vessel 14, for example, stomach 12 right in here. Those interact with a large number of meridians. And this is a very easy reference to go by. So here's the large intestine muscle meridian. Here you have that area for musculoskeletal type of issues. Anyway, just go down through this and make a note of them. And when somebody comes in, presents with those particular organ problems, with certain musculoskeletal issues, stimulate those points. You'll be surprised how many of them come along just very quickly. Just take out a Teijin, just go through and click, 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 and stimulate them. And you'll be surprised how many of those come right along. Now here is the spleen meridian. I don't agree with the placement of the spleen 21. I have found that you have to go back against the lat muscle right up next to it, about the 5th or 6th rib level, and that works a lot better than right here. We'll discuss that somewhat more later on. Here's the heart main meridian, and look at all the areas that treats. There's the heart muscle meridian. This would be the musculoskeletal type of issue, and you would stimulate those particular points for that. Small intestine main meridian. There are the organs. And you can go through this in the notes that we've given you and just pull them out and make a flip chart. And just start to think in the manner of when I have somebody with an organ issue like this, then I should look at that particular meridian, possibly stimulate those points. Musculoskeletal type issues, go to the muscle meridians and stimulate those. And here's just a quick reference, and that's just going down through there. And that's what I've provided this for. I would encourage you to purchase these if you can still get them. Look where the meridians run and stimulate those. Are the meridians set in stone? No, they vary by individual. They vary by ethnicity. And here they even change. He says in slight changes in nomenclature. Meridians of acupuncture, atlas of acupuncture, new additions, they've changed from where they were in the previous one. I've seen some things that altered from the Yellow Emperor's Classic. They deviated from it and then they went back to it later on in later editions. So they went back to what it was originally, and that kind of makes me laugh, but that's the way of things. 9J1, and here's another way of looking at the same organs. This is Royston Low, and you take the very same ones and he has different pathways. This is different than what you will see in Felix Mann's. He has a little bit different take on it, and this may come in handy for you when you start looking at these variances. And basically I've provided that for you so you can see these things, and we don't have to go through each individual one, but I would encourage you to go through them yourself, and you will see things in one master acupuncturist take that are not in another one's, and sometimes that one will give you a little bit better results than somebody else's. I just encourage you to go through these over and over and over again. Have them kind of handy so that you can look at them. Just flip through them every day. Figure out your own method of how you want to deal with them. Now you notice this spleen 21 is not in the same position. Felix Mann's is up over here. Like I said, I find it back here more consistent, very consistently. And so I don't happen to go along with either of those. So I'm doing this by virtue of showing you differences one from another, and never rely on just in one source. It'd be the same as a chiropractor going to one adjusting seminar, and that's the only seminar that he ever takes. Well, other seminars have different takes, different ways to manipulate, and you may find that you do better with one person's versus another's, and you get better results doing it that way, and that's how you do it in your practice. Well, it's the very same with acupuncture, very same type of thing. 9J2, the third nervous system. I know you can go online and they're not going to list it like this, but this is basically the original one that was talked about. So let's cover this. What are the first two? Well, the autonomic and the somatic divisions. The chromaffin system. Chromaffin cells, pheochromocytes, are classically defined as elements derived from neuroectoderm, innervated by preganglionic sympathetic nerve fibers, capable of synthesizing and secreting catecholamines such as dopamine, noradrenaline, or adrenaline. Groups of such hormone-secreting cells are associated structurally and functionally with the sympathetic nervous system. This system comprises a large number of masses of tissue similar in development, structure, and histochemical reactions to the medulla of the suprarenal or adrenal gland, called chromaffin because of its affinity for chromium salts. The masses of tissue all originate in intimate association with the sympathetic nervous system and the characteristic chromaffin cells. The neurons of the sympathetic ganglia are derived mainly from a common mother cell, the cell of the neural crest. It includes the medulla of the suprarenal gland, the extra suprarenal chromaffin bodies, which may occur in any part of the sympathetic system, though they are most numerous in the abdomen. The majority of the extra suprarenal chromaffin bodies are adjacent to the aorta, the para-aortic chromaffin bodies, and some cells in the wall of the intestine contain granules giving the chromaffin reaction and are termed enterochromaffin cells. The extra suprarenal chromaffin bodies are encapsulated structures. Non-encapsulated collections of chromaffin cells may be associated with any of the sympathetic ganglia. The largest collections of abdominal para-aortic chromaffin bodies are found in the celiac and mesenteric plexuses. The carotid body, or glomus caroticum, is situated close to the bifurcation of the common carotid artery, adjacent to the carotid sinus, sometimes wedged in between the roots of the internal and external carotids, or at a higher level, and shows a slight chromaffin reaction, but not considered part of the chromaffin system. The corpus coccygeum is a small vascular body lying immediately anterior to the tip of the coccyx, in intimate relation with a branch of the median sacral artery and with the ganglion impar of the sympathetic trunk in a group of smaller bodies of similar structure. The corpus and its satellite bodies are enclosed in a fibrous capsule, ensheathing them individually, not giving a chromaffin reaction or included in the chromaffin system. All chromaffin tissue develops in intimate relation with the sympathetic nervous system, the sympathetochromaffin tissue. This includes the medulla of the suprarenal glands, para-aortic bodies, paraganglia, carotid bodies, and small masses of cells scattered irregularly and variably among the ganglia of the paravertebral sympathetic chains. Splanchnic nerves in the great prevertebral autonomic plexuses may be closely related to various organs such as the heart, liver, kidney, ureter, prostate, epididymis, ovarian, etc. Enterochromaffin cells are found in the epithelial tissue lining the gastrointestinal and respiratory tracts, and the amine storing mast cells found in connective tissues of the gut, pancreas, and liver. These have ability to take up and decarboxylate amino acids, or APID cells, and other non-chromaffin cells in the walls of the gastrointestinal and respiratory tracts, pancreas, and other endocrine glands, have similar ultrastructure and amino acid uptake characteristics. Paraneurons having many of the features of chromaffin cells in sympathetic ganglia raise questions about the advisability of continuing to restrict the term chromaffin system to the true chromaffin cells. May be more appropriate to consider it as part of a diffuse neuroendocrine system. In 1938, the studies of Furter drew attention to the existence of isolated groups of hormone-secreting cells which were not restricted to specific endocrine glands, but were widely scattered throughout the tissues of the body. Furter described these cells as clear cells, or helizellin, and noted that they were particularly prominent in the gut and the pancreas. They have since been classified as types of APID cells, or amine precursor uptake and decarboxylation. Their characteristic amine handling properties and have been shown to manufacture structurally related peptides which act as hormones or neurotransmitters, although in others the main secretion is a similarly acting amine. Collectively, the APID cells comprise a system far more extensive than that visualized by Furter, including among others chromaffin cells, Sif cells, peptide-producing cells, the hypothalamus, pituitary, pineal, parathyroids, and placenta, and the Cholkitsky cells of the lung. So far, some 40 different cell types have been categorized as the diffuse neuroendocrine system. Peirce proposed that cells manufacturing peptide hormones shared a common set of cytochemical characteristics, the most striking being related to the production of biogenic amines, or adrenaline, noradrenaline, dopamine, 5-hydroxytryptamine, etc., could be linked to the process of peptide hormone production in general, from which the designation APID cell arose. Peirce suggested that all cells of the APID series are derived from neuroendocrine programmed cells of the ectoblast. Others suggest that some APID cells, such as the gastro and enteropancreatic endocrine cells, may be similarly programmed, but of endodermal origin. Peirce suggested the APID cells may collectively be considered as a third division of the nervous system, acting as third-line effectors to support, modulate, or amplify the actions of neurons in the autonomic and somatic divisions and of each other. In other words, this is a negative feedback system. And when some hormones are lacking, the nervous system alerts the brain and the different organs and says, hey, we need some more of these. If they're in excess, the nervous system says, hey, we need less of these. So this is part of the negative feedback system, without which we could not live. They possess activities which are slower in onset and longer in duration than those of cells in the autonomic division, which in turn bear a similar functional relationship to the faster acting neurons of the somatic division. Various secretions of the apid cells of the diffuse neuroendocrine system, may act upon contiguous cells, upon groups of nearby cells, or upon distant cells after transport in the blood, in this respect being considered as intermediate between the locally acting transmitters produced by neurons and the distantly acting secretions of the discrete endocrine glands. So basically they're already being produced in the cells, and when the cells need more, the larger organs act as a support system for them through the nervous system. The diffuse neuroendocrine system thus complements and links the nervous and endocrine systems, all three systems interacting to provide a sensitive mechanism allowing for homeostatic control. It has been suggested that deviations in the relative levels of the secretions of the different cell types of the diffuse neuroendocrine system may result in many of the disorders currently described as psychosomatic or frankly psychotic, which may lead to significant clinical progress in their treatment. The suprarenal medulla is composed of groups and columns of chromaffin cells that synthesize and secrete noradrenaline and adrenaline into venous sinusoids, the release being under preganglionic sympathetic control. The paraganglia are generally defined as extra-adrenal aggregations of chromaffin tissue widely distributed along and within the autonomic nervous system, adjoining various autonomic ganglia. Cells similar to those which characterize various autonomic ganglia are also found within sympathetic ganglia, where they are referred to as small, intensely fluorescent, or SIF cells, in the walls of various viscera and in a variety of retroperitoneal and mediastinal locations. The interneurally disposed act as interneurons, and the remainder are sources of a variety of endocrine secretions, including tryptophan-containing protein as well as catecholamines. This diffuse collection of extraadrenal chromaffin tissue is referred to as the paraganglion system. Type 1 cells of the paraganglia receive a preganglionic sympathetic innervation like that of chromaffin cells of the adrenal medulla. Paraganglia should be considered as endocrine glands whose secretory manufacture catecholamines and proteins stored until stimulated to be released by intrinsic and extrinsic factors. As well as having a remote endocrine effect, local paracrine actions by these secretions on nearby cells occur. The paraganglia collectively comprise a diffuse system which may act throughout life as a source of catecholamines, additional to those provided by the adrenal medulla, assuming a role of considerable metabolic and clinical significance. In adults, para-aortic bodies are present as discernible structures, mainly in the vicinity of the celiac and superior mesenteric arteries, while only microscopic collections of chromaffin cells persist in association with the lower parts of the intermesenteric plexus. Although the chromaffin cells of the sympathetic ganglia may act as interneurons, those of the other extraadrenal chromaffin tissues are endocrine in nature and probably subserve the adrenal medulla as sources of catecholamines. There is also ultrastructural evidence that chromaffin cells associated with nodes of the solar plexus have processes extending beyond the ensheathing glial cells towards blood capillaries into which the catecholamines pass. Now, I would go just the opposite of this. I think the adrenal medulla subserves these others. They support them. Carotid bodies are innervated by the carotid branches of the glossopharyngeal nerve, including the carotid sinus nerve, and by a fine plexus containing glossopharyngeal, vagal, and sympathetic components. They are arterial chemoreceptors which when stimulated by hypoxia or hypercapnia, when you have too much carbon dioxide in your bloodstream, or elevated hydrogen ion concentration in the blood, elicits a reflex increase in the rate and volume of ventilation through neural connections with the array of respiratory centers in the brainstem. They have tightly packed collections of glomerulus type 1 cells storing dopamine, other transmitters, and the protein glomin, and are accepted as a variety of chromaffin cell perineurons and dopaminergic interneurons. The above is why an instant shot of adrenaline at the sympathetic nerve synapses for fight or flight instead of waiting the average of 1 minute for average adult body circulation to bring it around. So basically you have chromaffin cells at the sympathetic synapses, and it takes about a minute for the blood to go through an average adult. So when you see a lion coming at you, you think, oh, I need an adrenaline response. It's going to take a minute for it to go around to get there so I can have it. Oh, I'm watching my watch. Hope that starts to kick in soon. Or does it just happen? It happens immediately because the adrenaline is already at the sympathetic synapse. The organ supports what's already there. Okay? This is why you can also stimulate the appropriate chromaffin and sympathetic nerve ending connection to stop allergic reactions. So what does the medical profession give for severe allergic reactions? Adrenaline. Why does your body not react with adrenaline so the allergy isn't severe? Well, it's the problems at the nerve synapses, such as scar tissue. So correct this by treating the appropriate synapses appropriately, and the allergic reactions won't occur. So you have a somebody who comes in and they have an allergy. Well, you ask them, okay, what are you allergic to? And it could be something that they just smell it and they react to that, or they have to put it under their tongue. Well, you take the small tip prod and you go down the ganglia on either side of the spine. Basically, they're on the above the heads of the rib articulations with the vertebra, and you go down those, and and this is where the bladder meridian is. And those, let's say they're cleared out, you clear them out. Then you introduce whatever they're allergic to. Well, it's going to light up the areas that are not functioning properly. So then you can go down and treat those, and the person now is not allergic because the appropriate reaction from the adrenal tissue, the chromaffin tissue, occurs, and your body reacts properly with its own adrenaline, so you don't need that adrenaline shot. I've had several people do this, and they are just like, oh my gosh, that helps so much with the allergies. Got rid of my allergies completely, or most of them. Okay, and you may have to search around the rest of the body for certain ones, but most of them are going to be on the inner part of that bladder meridian, where the sympathetic ganglia chains are on either side of the vertebra. 9J3, internuncial neurons. Secondary hyperalgesia associated with deep or superficial injury causes increased excitability in the network of internuncial neurons, which receive convergent noxious impulses from cutaneous and deep somatic or cutaneous and deep visceral tissue structures. Injury to skin produces hyperalgesia, and as a result, nerve endings become hyperexcitable, consequently barraging the dorsal horn with noxious impulses that sensitize the dorsal horn neurons to such an extent that they would be excited by subliminal stimuli. Secondary hyperalgesia, or allodynia pain, caused by non-noxious stimulus to normal skin that does not normally provoke pain, is caused by sensitization of wide dynamic range neurons in the dorsal horn. Changes take place in the spinal cord and primary afferent and spinal neurons that can produce such changes in nociceptive responses, collectively termed central sensitization, which may last many minutes to hours after a repeated afferent input ceases or is blocked. This also applies to chronic pain models, inflammatory due to tissue injury, and neuropathy from damage to nerves. The interaction between the immune and nervous systems makes this a somewhat arbitrary distinction, in that immune cells can mediate nerve damage, and nerve damage may activate immune cells, or the neuroimmune system. Inflammatory agents given on the skin, such as acetic acid, which is in vinegar, carrageenan, a substance extracted from red and purple seaweeds, consisting of a mixture of polysaccharides used as a thickening or emulsifying agent in food products, capsaicin, formalin in clothes, carpet, drapes, furniture, etc., like formaldehyde, and mustard oil, have all been given on the skin or viscera to produce pain responses or facilitations in pain responses developing within seconds to days. These result in ongoing withdrawal patterns and central sensitization from ongoing peripheral mechanisms, contributing to pain behaviors from initiation of several second messengers, causing the lingering effects, leading to patients learning to hurt. Healthy individuals generally don't perceive light digital pressure stimulus to be painful. Therefore, this finding in fibromyalgia syndrome, or FMS, seems to represent a lower than normal pain threshold than meets the clinical definition of allodynia. For that reason, it was proposed that fibromyalgia syndrome could be viewed mechanistically as chronic widespread allodynia. Two studies conducted in Canada and the United States found that approximately 65% of the general population are free of pain, 5% transient, 20% regional, 10% have widespread pain. Chiropractors see about 17% of the population annually and have seen about 75% at some point in their lives. A lot more than we're told. 2% of the general population have fibromyalgia syndrome, sufficient to meet American College of Rheumatology criteria. 6 to 10% of patients in a typical physician's waiting room meet criteria for fibromyalgia. About 1 in 10. Gross anatomy gives little indication of the functions of the central nervous system beyond those inferred from the peripheral connections of the various nerves. Knowledge of functional significance of the various parts of this system based on their structure can only be obtained with any certainty from a study of the connections of the group of cells, but no complete picture of the connections of the cells in the nervous system is available, and the anatomical approach to the study of its function cannot yet produce more than a very sketchy outline. The divisions of the central nervous system, based on gross anatomy, represent parts of a unit concerned with integrating the activity of every part of the body. This system requires a high degree of integration of its parts attained by nerve fibers connecting the various regions of the central nervous system reciprocally. The central nervous system consists of 3 types of cells: sensory, connector or internuncial, and motor. Sensory neurons have 2 processes, one of which passes to a sensory ending, the cell body lying outside the CNS, either in the spinal ganglia of a dorsal root or in corresponding ganglia of cranial nerves adjacent to the brain, the retina, the olfactory mucous membrane. The other process enters the central nervous system and extends for a variable distance, giving rise to a number of branches through which it can activate several internuncial neurons. Internuncial neurons are imposed between the sensory and motor cells and are not directly connected either with a sensory ending or with an effector organ. They comprise almost all the gray matter of the CNS. So basically, the internuncial neurons are almost entirely the whole central nervous system, including large structures such as the cerebrum, cerebellum, thalamus, corpus striatum, many small nuclei, more scattered groups of nerve cells. They lie entirely within the CNS, excepting the preganglionic cells of the autonomic nervous system, sending axons to the peripheral autonomic ganglia consisting of motor cells. They perform the pathways through which impulses pass for production of local reflexes and link together the parts of the CNS. At all levels of the CNS and local and distant connections, they act together in constantly changing patterns, depending mainly on the varying sensory impulses entering the nervous system. Their interactions result in the free passage of impulses through certain nervous pathways, while other pathways are blocked or inhibited so inappropriate reactions don't take place. The continuous interplay of facilitation and inhibition within the complex network of internuncial neurons eventually affects motor cells to produce overt reactions such as muscular contraction or inhibition, vasoconstriction or dilatation, glandular secretion or inhibition, and etc. They interrelate the vast numbers of sensory impulses pouring into the nervous system over a wide area, transmitting the sensory information to every part of the nervous system, an essential part of any integrating system. So the gray matter basically is the integrating system, and it lets every part of the nervous system know what every other part is doing. Otherwise you can stand or sit or almost fall over and catch yourself and things of this nature. The certain sensory regions seem to be capable of evoking subjective awareness of sensation in man, the cerebral cortex. Conveying impulses headward to the sensory regions from the spinal medulla and brainstem are frequently called sensory tracts, though they only differ from similar fibers carrying the same information to other regions, like the cerebellum, in that their destruction interferes with the conscious awareness of certain sensations. All the various regions of the CNS are connected with those lying caudal to them, and such descending connections produce effects on the caudal parts of the nervous system similar to the effects of the ascending connections on the more cranial parts. However, since all the motor cells lie in the brainstem and spinal medulla, activity in the descending pathways like the cerebral cortex often results in production of a movement or other activity which can readily be observed, for which reason the descending pathways and cells which give rise to them are frequently called motor. However, ascending pathways connecting various segments of the spinal medulla with each other or with the brainstem may equally produce motor effects through motor cells at those levels. Any movement produced by activity in internuncial neurons at the same or different level of the CNS calls for inhibition of local activity at variance with the movement which the motor pathway is producing, in addition to the inhibition of the antagonist muscles. The motor pathways composed of internuncial neurons are therefore of necessity also inhibitory in their actions. The terms sensory and motor must therefore be applied with caution to the pathways composed of the axons of internuncial neurons, since they are not equivalent to the same terms applied to nerve cells attached to either sensory endings or true sensory neurons, or to the effector organs, true motor neurons. So things that we consider sensory and motor aren't necessarily the same in the central nervous system. Sensory information from the receptors of the entire body surface and from some deep structures enters the central nervous system through the peripheral nerves and is conducted to multiple sensory areas. Signals are then relayed to essentially all other parts of the nervous system. The most important ultimate role of the nervous system is to control the various bodily activities. This is achieved by controlling contraction of skeletal muscles, contraction of smooth muscle in the internal organs, and secretion by both exocrine and endocrine glands, collectively called motor functions of the nervous system, called effectors because they perform the functions dictated by the nerve signals. The major function of the nervous system is to process incoming information in such a way that appropriate motor responses occur. So basically, the nervous system wouldn't develop at all if it weren't for sensory input. Therefore, our job is to correct the sensory input. The nervous system, with the exception of our conscious thought, is just reactionary, pure and simple. It's a negative feedback system. Position sensory receptors. Knowledge of position, both static and dynamic, depends on knowing the degrees of angulation of all joints in all planes and the rates of change. Therefore, multiple different types of receptors help to determine joint angulation and are used together for position sense. Both skin tactile receptors and deep receptors near the joints are used. In the case of the fingers, where skin receptors are in great abundance, as much as half of position recognition is believed to be detected through the skin receptors. For most of the larger joints of the body, deep receptors are more important. After the important sensory information has been selected, it is then channeled into proper motor regions of the brain to cause the desired responses, called the integrative function of the nervous system. Thus, if a person places a hand on a hot stove, the desired response is to lift the hand, or flexion reflex, and other associated responses such as moving the entire body away from the stove. The storage of information is the process we call memory, a function of the synapses. Each time certain types of sensory signals pass through sequences of synapses, these synapses become more capable of transmitting the same signals next time, which process is called facilitation. After the sensory signals have passed through the synapses, a large number of times the synapses become so facilitated that signals generated within the brain itself can also cause transmission of impulses through the same sequences of synapses, even though the sensory input has not been excited. This gives the person a perception of experiencing the original sensation, although in effect they are only memories of the sensations. So this answers the question as to why, when somebody had an injury 5 years, 10 years, 20, 30, 50, 60 years ago, they still have the same symptoms, maybe worse. Well, it's that the brain is perceiving that the incident is still fresh. So your job and mine is to erase the memory of the injury from the central nervous system using or utilizing the peripheral nervous system. Non-adapting nature of pain receptors. In contrast to most other sensory receptors of the body, pain receptors adapt very little, sometimes not at all, because it allows them to keep the person apprised of a damaging stimulus that causes the pain as long as it persists. Inhibition of pain transmission by tactile sensory signals. Large type AB sensory fibers from the peripheral tactile receptors can depress the transmission of pain signals, resulting from a type of local lateral inhibition. Now this is interesting because it supports chiropractic here. The spinal cord is a conduit for signals from the periphery of the body to the brain or in the opposite direction. Neuronal circuits in the cord can cause walking movements, reflexes that withdraw portions of the body from painful objects, reflexes that stiffen the legs to support the body against gravity, reflexes that control local blood vessels, such as high and low blood pressure, gastrointestinal movements, digestion, and so forth, in addition to many other functions. So standing against gravity, sitting, etc., etc. I show this to patients when they say that my medical doctor, my registered nurse says that chiropractors are unscientific quacks. So I open this up in the 5th edition of GAIT, and I have it highlighted, and I say, read this aloud. After this, they're just flabbergasted, and they say, well, why didn't they tell me this? I say, I don't know, they have the same textbook I do. It's right in there. So now you've changed this patient from just a pain musculoskeletal patient to them asking you about every area of your practice, every type of health care type of thing. Many functions of the nervous system, such as the process of memory, requires prolonged changes in neurons for seconds to months after the initial transmitter substance is gone. The ion channels are not suitable for causing prolonged postsynaptic neuronal changes because these channels close within milliseconds after the transmitter substance is no longer present. In many instances, Prolonged neuronal action is achieved by activating a second messenger chemical system inside the postsynaptic neuronal cell itself. Then the second messenger causes the prolonged effect. So when a patient gets well with you very quickly with the type of condition they've had for years, send them back to the previous practitioner. It doesn't matter whether it's an MD specialist, another chiropractor, a physical therapist. And they will inevitably call you up and say, I've been struggling with this patient. What did you do for years? I just say, well, I stimulated the large type A-B sensory fibers to activate the central analgesia system and shut off the second messenger, causing the prolonged effect. It's right there in guidance. And they are usually just flabbergasted because, they've forgotten all that if they ever knew it. Mechanoreceptors detect mechanical deformation. Nociceptors detect damage occurring in the tissues. Pain receptors in the skin are almost never stimulated by usual touch or pressure stimuli, but do become highly active the moment the tactile stimuli become severe enough to damage the tissues. If a pain fiber is stimulated, the person perceives pain regardless of what type of stimulus excites the fiber. Likewise, if a touch fiber is stimulated by exciting a touch receptor in any way, the person perceives touch because the touch fibers lead to specific touch areas of the brain. So you don't have to use necessarily large amount of pressure. Touch fibers can cause some problems. All sensory receptors have one feature in common. Whatever the type of stimulus that excites the receptor, its immediate effect is to change the membrane potential of the receptor. This change in potential is called a receptor potential. Mechanical deformation of the receptor stretches the receptor membrane and opens ion channels. The Pacinian corpuscle has a central nerve fiber extending through its core. Surrounding this are multiple concentric capsule layers so that compression anywhere on the outside of the corpuscle will elongate, indent, or otherwise deform the central fiber. The mechanism by which a receptor potential is produced in the Pacinian corpuscle, the small area of the terminal fiber that has been deformed by compression of the corpuscle, note that ion channels have opened in the membrane, allowing positively charged sodium ions to diffuse to the interior of the fiber. This creates increased positivity in the fiber, which is a receptor potential, cause and action potential. The receptor potential in turn induces a local circuit current flow that spreads along the nerve fiber. Local current flow depolarizes the fiber membrane at the node. This then sets off typical action potentials that are transmitted along the nerve fiber toward the central nervous system. Receptors, called rate receptors, movement receptors, or phasic receptors in the case of the Pacinian corpuscle, sudden pressure applied to the tissue excites this receptor. The Pacinian corpuscle is exceedingly important in apprising the nervous system of rapid tissue deformations. Positive stretch reflex. The simplest manifestation of muscle spindle function is the muscle stretch reflex, also called myotatic reflex or muscle spindle stretch reflex. That is, whenever a muscle is stretched, excitation of the spindles causes reflex contraction of the large skeletal muscle fibers of the same muscle and closely allied synergistic muscles. The stretch reflex can be divided into two components. The dynamic stretch reflex is elicited by the potent dynamic signal transmitted from the primary endings of the muscle spindles caused by rapid stretch of the muscle. That is, when the muscle is suddenly stretched, such as a reflex hammer, a strong signal is transmitted to the spinal cord. This causes an instantaneous strong reflex contraction of the same muscle which the signal originated, and the reflex functions to oppose sudden changes in the length of the muscle because the muscle contraction opposes the stretch. The dynamic stretch reflex is over within a fraction of a second after the muscle has been stretched to its new length, but then a weaker static stretch reflex continues for a prolonged period thereafter. It continues to cause muscle contraction as long as the muscle is maintained at excessive length. Muscle contraction in turn opposes the force that caused the excess length. Negative stretch reflex. When a muscle is suddenly shortened, exactly opposite effects occur because of decreased nerve impulses from the spindles. And if the muscle is already taut, any sudden release of the load on the muscle that allows it to shorten will elicit both dynamic and static reflex muscle inhibition rather than reflex excitation. Thus, the negative stretch reflex opposes the shortening of the muscle in the same way that the positive stretch reflex opposes lengthening of the muscle. Therefore, one can begin to see that the stretch reflex tends to maintain the status quo for the length of a muscle. Flexor reflex and the withdrawal of reflexes. Cutaneous sensory stimulus on a limb is likely to cause the flexor muscles of the limb to contract, thereby withdrawing the limb from the stimulating object, the flexor reflex. In its classic form, the flexor reflex is elicited most powerfully by stimulation of pain endings, such as by a pinprick, such as an acupuncture needle, or heat, for which reason it's also called an nociceptive reflex, or simply pain reflex. Stimulation of the touch receptors can also elicit a weaker and usually less prolonged flexor reflex. If some part of the body besides one of the limbs is painfully stimulated, this part, in a similar manner, will be withdrawn from the stimulus, but the reflex may not be confined to flexor muscles, even though it is basically the same type of reflex. Therefore, the many patterns of reflexes of this type in the different areas of the body are called withdrawal reflexes. So basically, you have withdrawal reflexes put you in a withdrawal or a crouch position, and you get stuck there in facilitation. Pathways for eliciting the motor reflex do not pass directly to the anterior motor neurons, but instead pass first into the interneuron pool of neurons, and only secondarily to the motor neurons, diverging circuits to spread the reflex to the necessary muscles for withdrawal. Circuits to inhibit the antagonist muscles, called reciprocal inhibition circuits. Circuits to cause a prolonged repetitive after discharge, even after the stimulus is over. I think this is something because the right in the middle in acupuncture, here you have the interneuron pool of neurons, and in the acupuncture area it's called governing vessel, in the middle conception vessel, and they don't interact with other areas, but they form a lake. Here it's called the interneuron pool of neurons, and so excess out of the lake goes to the other, and if there's excess in those, they're dumped into the conception vessels or governing vessels to act as a lake. So very similar terminology. Pattern of withdrawal. During this time, other reflexes and actions of the central nervous system can move the entire body away from the painful stimulus. The pattern of withdrawal that results when the flexor reflex or the many other types of withdrawal reflexes is elicited depends on the sensory nerve that is stimulated. Thus, a painful stimulus on the inside of the arm not only elicits a flexor reflex in the arm, but also contracts the abductor muscles to pull that can most effectively remove the pain part of the body from the object that caused the pain. This same principle, called the principle of the local sign, applies to any part of the body, but especially to the limbs, because they have highly developed flexor reflexes. So let's say that you're hit from one side to the other. You're hit here, makes your leg go out. So that's called the magnetic reaction. But you keep walking with that leg going out like you're falling to the side. Well, how do you take care of it? Right here is where you stimulate. You stick a needle in there, you put a prod, you pinch the area, and immediately corrects the withdrawal reaction that is here, and maybe some scar tissue forms and it's remembered, and your body keeps withdrawing from that. So apply that to anything. Maybe you're hit on the hip and you go to the side. Then you would apply it to that spot that you were hit on in the hip. Maybe you're hit from the back, maybe you're hit from the front, and etc., etc. So that's where you would apply the stimulus. That's where you would apply the prod or the needle or the pinch or anything like that to correct it. So I'm trying to get you to think about what may have happened, observe the person, ask a couple of questions, and reach a conclusion, stimulate that part, and you'll notice a very immediate correction. Crossed extensor reflex. About 0.2 to 0.5 seconds after a stimulus elicits a flexor reflex in one limb, the opposite limb begins to extend. This is called the crossed extensor reflex. Extension of the opposite limb can push the entire body away from the object, causing the painful stimulus in the withdrawn limb. It's certain that many interneurons are involved in the circuit between the incoming sensory neuron and the motor neurons of the opposite side of the cord, responsible for the crossed extension. Furthermore, after the painful stimulus is removed, the crossed extensor reflex continues for an even longer period of discharge after discharge than that for the flexor reflex. The prolonged after discharge would be a benefit in holding the body away from a painful object until other nervous reactions could cause the body to move away. So basically, you touch something hot, a hot plate response. You withdraw flexor reflex, crossed extensor reflex. These muscles remain in relative hypertonus, hypotonus, hypertonus, hypotonus, and so through the body as the entire body retracts. So to correct that, if there's scar tissue here, you would correct that scar tissue, and that would cause the whole body to come out of that withdrawal reaction. So you apply that anywhere to whatever type of reflex, withdrawal reflex is going on. You can find that very easily just by questioning. You don't have to go through a whole lot of acupuncture applications to find the diagnosis and all that. You just ask the question. You find where the trauma was. You correct the withdrawal pattern by correcting the scar tissue where the injury was. You do it with a needle, with a prod, with a pinch, something of this nature, okay? Reciprocal inhibition and reciprocal innervation. Excitation of one group of muscles is usually associated with inhibition of another group. For instance, when a stretch reflex excites one muscle, it is often at the same time. It often at the same time inhibits the antagonistic muscles. This is a phenomena of reciprocal inhibition, and the neuronal circuit that caused the reciprocal relation is called reciprocal innervation. Likewise, reciprocal relations often exist between the two sides of the cord, as exemplified by the flexor and extensor reflexes described above. Reflexes of posture and locomotion. Pressure on the foot pad causes the limb to extend against the pressure being applied to the foot. This reflex is called the positive support reaction. It involves a complex circuit in the interneuron similar to those responsible for the flexor and cross extensor reflexes. The locus of the pressure on the pad of the foot determines the direction in which the limb will extend. Pressure on the one side causes extension in that direction, an effect called the magnetic reaction, which we just stated. This keeps an animal from falling to that side. Laid on its side, the animal will make movements that indicate trying to raise and to the standing position. This is called a cord riding reflex. Such a reflex demonstrates that relatively complex reflexes associated with posture are integrated in the spinal cord. So all this goes back to the spinal cord again. Oscillation back and forth between the flexor and extensor muscles seems to result mainly from mutually reciprocal inhibitions circuits that oscillate between the neurons, controlling the agonist and antagonistic muscles within the matrix of the cord itself. The sensory signals from the foot pads and from the position sensors around the joints play a strong role in controlling foot pressure and rate of stepping. When the foot is allowed to walk along a surface, in fact, the cord mechanism for control of stepping can be still more complex. For instance, if during the forward thrust of the foot, the top of the foot encounters an obstruction, the forward thrust will stop temporarily, but then in rapid sequence the foot will be lifted higher and proceed forward to be placed over the obstruction. This is the stumble reflex. Thus the cord is an intelligent walking controller. Last weekend we just did this on one of the doctors. We said, okay, stand up and walk, and one of the feet went forward a lot quicker than the other one. I said, okay, you probably tripped on something in the past. And so I said, take off that particular shoe and sock, and he did. And I took the small tip probe and we went on top of the foot. Basically here are the toes, and we went about right here. I figured, well, the stumble probably happened somewhere between here and here. Sure enough, right there it was sensitive. So we took the small tip prod and we went over it, and we got that corrected. And now I walked straight without that leg quickly going forward like he was stumbling on every step. Basically, we took away the perception in the brain that that object was still there, that the scar tissue from that little bit of injury kept telling the brain, so that he had that stumble reflex just continually. Okay, and I hope I'm giving you examples from this. And you can use the small tip prod, you can use pressure, you can use skin roll, you can use needles, you can use any of those things, but you got to break up that scar tissue in that damaged area. Then the signal will go back to the brain, hey, that's not there anymore, you can quit stumbling. Okay? This applies to about anything in the body. Just let your brain run wild. Don't use these complex acupuncture type of diagnoses. Just think, okay, what could have happened? Observe the patient, ask a few questions. You will know where to treat very quickly and get a very, very quick response. Every time stepping occurs in the forward direction in one limb, the opposite limb ordinarily steps backward. This effect results from reciprocal innervation between the two limbs. So the reciprocal innervation is not just within a limb, it's between two limbs. It's a gait reflex basically, and between the upper limbs. So when you do any of this, you're going to affect one side, the other side, and the upper limbs. And basically, it's going to affect all the proprioceptive receptors and get the person working normally the way that they should, and quit adapting to these withdrawal reflexes, stumble reflexes, etc. In general, stepping occurs diagonally between the forelimbs and hind limbs. Such a walking pattern is called a mark time reflex. In applied kinesiology, they call it cross crawl. When you're talking with somebody in the medical field, don't use cross crawl. Their eyes are going to cross. Use the term mark time reflex for gait reflex, walking patterns. A muscle reflex that may further stimulate the sympathetic nervous system. Aside from the sympathetic stimulation caused by direct signals from the brain, reflex signals from the contracting muscles pass up the spinal cord to the vasomotor center and to excite the sympathetic nerve still further. These signals are initiated by metabolic end products acting on small sensory nerve endings in the muscle tissue. Vestibular postural reflexes. Sudden changes in the orientation of an animal in space elicit vestibular reflexes that help to maintain equilibrium and posture. For instance, if an animal is suddenly pushed to the right, even before it can fall more than a few degrees, its right leg extends instantaneously. That's that magnetic reaction. Another type of vestibular postural reflex occurs when the animal suddenly falls forward When this occurs, the forelegs extend forward, the extensor muscles tighten, and the muscles in the back of the neck stiffen to prevent the animal's head from striking the ground. So basically, if somebody's shoulders are forward, if they kind of walk in a head-up position, they probably had like this, something like this happen. If they were pushed backwards, you know, head would be forward like this, the neck would be lurched, and you would have that sort of thing. So you have to imagine in your mind's eye, where was this person struck from? So where did the damage occur? So where do I apply the needle, the prod? Where do I pinch? Where do I apply digital pressure? Figure it out in your mind's eye. You find that point. That's the point that you need to treat. Vestibular mechanism for stabilizing the eyes. When a person changes direction of movement rapidly or even leans the head sideways, forward or backward, it would be impossible to maintain a stable image on the retina of the eye unless the person had some automatic control mechanism to stabilize the direction of gaze of the eyes. Each time the head is suddenly rotated, signals from the semicircular ducts cause the eyes to rotate in a direction equal and opposite to the rotation of the head. So if you tell somebody, turn your head but keep looking at my finger with your eyes, and they can't do it, then you know that there is something wrong with that mechanism in there, and you have to go maybe over the semicircular canals to help correct that, because that's a nystagmus type of issue. Neck proprioceptors. The vestibular apparatus detects the orientation and movements only of the head. Therefore, it's essential that the nervous centers also receive appropriate information depicting the orientation of the head with respect to the body. This information is transmitted from the proprioceptors of the neck and the body directly to the vestibular and reticular nuclei of the brainstem, and indirectly by way of the cerebellum. Among the most important proprioceptive information needed for maintenance of equilibrium is that transmitted by the joint receptors of the neck. When the head is leaned in one direction, bending the neck, impulses from the neck proprioceptors keep the vestibular apparatus from giving the person a sense of mal-equilibrium, signals that exactly oppose the signals transmitted from the vestibular apparatuses. However, when the entire body leans in one direction, the impulses from the vestibular apparatuses are not opposed by signals from the neck. So here you may have some problems on the bottom of the feet, or you may have problems in the neck. Maybe there's damage to the neck, you need the needle, maybe the problems from the damage to the bottom of the feet. Importance of visual information in the maintenance of equilibrium. Proprioceptive information from other parts of the body besides the neck is also important in the maintenance of equilibrium. Pressure sensations from the foot pads tell whether weight is distributed equally between the 2 feet and weight is more forward or backward on the feet. So you can look at somebody, how they're leaning to one side or the other, and they may be leaning away from the side where the injury is, for example. So you would needle that part of the bottom of the foot, for example. Maybe they're having trouble sitting. Maybe it's on the bottom of the buttocks where the problem is, or on the ischium itself, on the periosteum of the ischium, and you need to scrape that, and that will correct it. So look at the position, look at where they're having trouble with, and imagine in your mind's eye, well, what are they trying to compensate for here? And that will direct you to where to treat with the needle or the prod or digital pressure or what have you. Man walks in an upright position and his limbs have become straightened to the point that almost no muscular strength is required to maintain the weight of the body against gravity. For instance, the direct line between the center of mass of the body and the direction of gravitational pull runs slightly behind the axes of the hip joints, so that gravity tends to extend the hips and so that the ligaments of the hip joints, rather than the muscles, support the body against gravity. You know, I tend to disagree with this somewhat, because I think that the weight is sitting directly on the head of the fibula and not just behind it. Because that's basically where the weight is. And I've found that when I do it that way, I get much better results. So I think this is a supposition more than anything. This is not the only place that I have seen this particular thing, that the line of gravity goes a little bit behind the hips. But I've found that when I try to do this, it actually throws the person off if I look at it in that fashion. But when I look at it that the acetabulum is sitting directly on the femoral head, then I get the correction that I want. The stretch reflex is considered essential in maintaining muscle tonus and can produce increased tension of certain muscle groups so as to provide a background of postural muscle tonus against which voluntary movements can occur. Most reflex arcs include at least one internuncial neuron between the afferent and efferent fibers. The stretch reflex has no such internuncial or intermediary neuron, and the afferent neuron makes direct contact with the efferent neuron across a single synapse in the cord. Now before, the same textbook did not agree with that. It said everything goes into the internuncial pool of neurons and affects proprioception. So I don't entirely agree with this. Stretching a muscle stimulates its muscle spindles. Afferent nerve fibers from muscle spindles enter the spinal cord through dorsal root nerves, go anteriorly through the gray matter of the spinal cord to reach the anterior horn, where synapses with motor cells are made. Higher supraspinal motor centers are believed to send impulses to skeletal muscles by two routes, one involving large alpha motoneuron cells, the other by small gamma motoneurons. The gamma neuron may be stimulated by afferent dorsal root fibers coming from the muscle spindles, so as to cause contraction of interfusal fibers via a stretch reflex. This appears adequate to activate the main muscle mass so that gamma innervation may serve as a starter for activation of the alpha motoneurons and the main muscle mass. So here we have the gammas stimulate the alphas. Proprioceptors. There are two main types of proprioceptors in joint capsules: Ruffini end organs or corpuscles and Pacinian corpuscles. Ruffini end organs appear to be mainly responsive to tension. Pacinian corpuscles appear to be responsive to compression. The proprioceptors in skin are similar to those found in the joint capsules. So here's where we come talking about some of the reactions from acupuncture. We're going right into the science, the Western science. Tension in skin can be caused by movement in a number of directions, and proprioceptors may make a significant contribution to joint stabilization in reflexive muscular activity. Skin proprioceptors, including Meissner's corpuscles, are located superficially in the skin and respond rapidly to transient movements of the skin. Pacinian corpuscles are found deeper in the subdermal layer of the skin. Pacinian corpuscles respond quickly to high-frequency transient movements of the skin. It is believed that these mechanoreceptors connect to the cortex, modify activities of the limbs, and joint and skin receptors also facilitate the vestibular apparatus to stabilize the extremities during gait by stimulating the necessary muscles to contract more forcefully and efficiently. So you can use the skin to affect all the underlying areas. This is Hilton's law of physiology right here. Skin proprioceptors identify environmental changes and provide information about your body's postural alignment. The Ruffini corpuscles are oriented with their long axes parallel to the surface of the skin and are most sensitive to skin stretch. Stretching the skin stretches the collagen fibers within the Ruffini corpuscle, which compresses the axon terminals. As the collagen fibers remain stretched, the axon terminals remain compressed during the skin stretch. Ruffini corpuscles, 1 degree afferent axon produces a sustained, slowly adapting discharge to maintain stimuli. Ruffini corpuscles in skin are considered to be skin stretch sensitive receptors of the discriminative touch system. They also work with proprioceptors in joints and muscles to indicate the position and the movement of the body parts. So the skin has to move over the underlying bone or muscle. Okay. Ruffini endings are located in the deep layers of the skin, register mechanical deformation within the joints, so the Ruffinis tell what the joint's doing. More specifically, angle change with specificity of up to 2 degrees, as well as continuous pressure states. They also act as receptors that respond for a long time. So in case of deep burn, there will be no pain as these receptors will be burned off. Skin stimulation changes muscle tone and joint angulation. So anything you do with the skin is going to change anything underneath, directly underneath it. The Meissners are superficial in the skin, Pacinian intermediate, Ruffini is deep, and you're going to stimulate all of these and affect everything underlying. This is very important to realize. 9K, great low points. Here is Acupuncture, a comprehensive text, Shanghai College of Traditional Medicine. Now, here's spleen 21, and again, I don't like where this is. I think it's more back, like right here, just in front of the lat, about the 5th or 6th rib level. You just search around for it. But here's another low. The stomach low point, sometimes called the heart low points, located directly under the mid-breast on the left to affect the whole cardiovascular system. So this comes into play. So you get a difficult patient, stimulate both of these with a teishin. Stimulate governing vessel 12 or 14 and 20, stomach 12. Also conception vessel 3, which we went over before. Also stimulate all the alarm points and stimulate point directly under the sternoclavicular joint, and that is kidney 27, which basically takes care of all of the associated points in the back. If you do all these, and throw in there large intestine 4, maybe spleen or stomach 36, you got a really difficult patient. Just take your teishin out and stimulate all those. Takes about 2 minutes. Thunk, thunk, thunk on each one. And it will take the veneer overcoating underlying problems. You will turn a big issue where everything is causing a problem. Now you only got 3 or 4 things to work on. Okay? And it's a very simple thing to do. 9L5. Here's Acupuncture, the Ancient Chinese Art of Healing by Felix Mann. And here's the law of 5 elements. Here are coupled meridians, whether they're yin or yang. And we see one flow of energy through all of them. Now we see 2 flows of energy. So what are these different things? Well, if one thing doesn't work, then you look for something else that works. And you find it and you put it down, and it's another law. And as we go through here, now here are the water points, the metal points, the earth points, the fire, the wood, and it shows their locations. So you have these handy. Here are some handy charts. There's the 24-hour clock. Again, on the 24-hour clock, if you're having trouble with kidneys, basically stimulate the horary point. And so if this is a water point like the kidney is, then you would stimulate the water point of the kidney right in this area. Okay? Or you would stimulate the one directly across from it during this period of time. So those work. So here's a law here, there's a law there. And you have 2 laws between them. Here's points of tonification. I don't put a lot of credence in these. Any point can act as a tonification or a sedation point. Everything goes toward normalization. And so we're going to, here's some source points. There's the alarm points. You can put that up. Remember, these are on both sides. These are unilateral only here. So you take your teishin, thunk, 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 thunk on each one of these. Do these bilateral again. Doesn't take a long period of time. There's associated points. Rather than do those, as a chiropractor, every time we adjust the thoracic area and the lumbar area, we're basically hitting those. You don't necessarily need to hit those. Hit kidney 27 just below the sternoclavicular joints to take care of all those in one fell swoop. A lot of times that will be enough right there. Kidney 27 is considered to act as the associated point for the whole series. Here's connecting points for a couple of meridians, points of entry and exit. Here's a flow, another flow of energy. Tonification point of entry, tonifies meridian. Sedation, reverse circumstances. In my experience, this effect is unreliable and unpredictable. I agree with that. Every point acts as sedation or tonification. Special meeting points, the 8 meeting points, the combining points, points window of the sky, points of the 4 C's, Shokanten, accumulating points, 5 categories, meeting points, and here's a whole list of meeting points. Look at all that. Origin and end points, root and side effect points, and here's charts that may come, they may help some. Pulse diagnosis. Now, Dr. Amaro talked about how he was in China and they had a dozen booths, and where people were doing pulse diagnoses, supposed experts. And so he went to each one individually, didn't tell them he was going to the other ones. Everyone had a different diagnosis. He didn't have a lot of faith in that. I really don't either. To be honest, you may, and that's great if you want to use that, go for it. 9L-1. Here's the how-to seminar of acupuncture for physicians. This is by Pinnell and Hauser. There's the 24-hour clock again, and here's this is the time span. It's 2-hour time span, 5 to 7 a.m., 5 to 7 p.m. And this has a certain application. Again, you would stimulate the horary points. Here's the midday, midnight effect, mother-child effect. Why do they have these? Well, because the last 2 dozen didn't work, so somebody had to come up with another one. And it's kind of like chiropractic. You got well over 100 different methods of adjusting the vertebra, because each of those found out that the other methods didn't work, so they came up with something different. Well, it's the same with acupuncture. Here's a general flow of energy, which is somewhat different than the flow of energy in the 5 elements. Okay? There's the 5 elements flow. Here's a chart of augmentation and inhibition through the 5 elements for your reference if you want to do that. Here's Speransky, intercalated or internuncial neurons, which we just went over. Intersection effect. Main thing I want you to get is how many different approaches there are. Now, here's a particularly good one, I think. Here you have an element of liver and gallbladder, and here are some things that may apply on a person. So put this chart up. If they come in presenting with certain symptoms, then say, hey, it's probably in one of these. So this is a fairly good reference point for that for any of the meridians. And you have all the 5 different elements and symptoms that may occur with them. when something's off. There's an alarm point chart that you can easily put up. It's bigger than the other one that we went over. There's the associated points, and I wouldn't worry a lot about those. Just, adjust the person and go to kidney 27 otherwise. Here's the Akabani or endpoints. And of course there are a couple endpoints that aren't there, but these are on the digits. On the feet in particular, I find them actually more under the nail and on the toe tip, and less so in the finger, but I've found in several people here recently in the fingers. So I tend to go under the nails. Well, where do the most meridians intersect? Well, here's conception vessel 3, which is about, in an adult, about an inch above the pubic symphysis. And this particular point is really, really good when you tap it very sharply for incontinence. And, I already discussed using that particular one on incontinence. Here's governing vessel 14. This is over the stellate ganglia between C7 and T1. Here's governing vessel 20. It's on the top of the head. And so when you're stimulating, when you have a person come in with a lot of problems, these are 3 that you want to stimulate, and it'll take care of a litany of problems without doing anything else. Okay, now here are, the meridians themselves, and just follow the paths. And here are different so-called needles. There are some abbreviations. Some of them deviate a little bit from those abbreviations, but those are basic ones. Here's how to pronounce things. Now, we're going to point out here a few special points. For example, here's lung 7 is good for edema. So anytime you have somebody, for example, that's had a surgery and they have edema from the surgery, you digitally press this or stick a needle in it, either one side or both sides, find out which one is tender, and you will get an immediate decrease in edema from that surgery case, and it could be the same day. And I've had several doctors go home and do that, and they're just astounded at what happened. And I described one of those cases to you earlier on, a couple of them that I had. Here, this actually goes to the other side. I think that the point 20 is right up here, and this is not so good a point. I find that it's consistently good behind and up on the nares, on that crease right there, the side of the nose right here. I do not agree with where the end point is here. And here we see different conditions. It seems to work within my experience, and I call these very special points because of that. Here's shoulder joint pain. You just stick it directly into the shoulder right here. You notice I have marked F for forbidden to the needle, so never use needles on these F points, okay? Because somebody in the past has gotten some very bad results with it. Here's frozen shoulder pain on large intestine 11 and 12, and of course 4-point, which you go to tip of the crease between the index and thumb. You go halfway over into the muscle and you point toward the pisiform, and that's how you do this. And it can be any body condition at all. People especially know it for headaches. And we discussed this point, earlier. Hemorrhagic conditions. When somebody presents with a nosebleed, for example, you have them pinch that thin part of the web right there, both sides at once, pinch very hard, and if you do that right now, you can feel something going on in your nose. It'll stop a nosebleed in about 7 seconds. I was giving a seminar in Indianapolis, Indiana, and one of the top 3 acupuncturists in the country who's taken all my seminars was there, and he said, "Dr. Bonebrake, that'll shut off any hemorrhage in the body." So I learned something there. I've been using it that way since. So hemorrhage anywhere in the body, pinch those both very hard at the same time. Here we have a forbidden to the needle point. Here's another one. There's arrhythmias and knee pain. It's right there on received tears. It's on the infraoptic notch. And swollen nasal passages right here is a very good spot. Swollen nasal passages, I gave that at the seminar last weekend. The guy pressed there and his nostrils opened up. He couldn't believe it. They'd been closed off for months and months, and they opened right up. Whole arm pain, neuralgias, paresthesias. We're going right here, and this is stomach 12. This is one of the points that when people have problems all over, this is one of the points that you stimulate, stomach 12. So don't forget to do that with your Teishin and somebody that's having a lot of problems. Forbidden to the navel, forbidden to the needle. Here you have pain inside the shoulder blades. It's not exactly on the nipple, it's probably in the areolar tissue around it. And you take the prod and you stimulate there. First time I had this, it was a female patient, and she was experiencing for years and years pain inside the shoulder blade. And I tried everything else and just wasn't getting it. And she, I thought of the 50-50 rule. Half the 50% of the time the cause on the opposite side or the opposite end of the body. So I started going down through everywhere, and right here there was a point in the areolar tissue. It shot straight back between the shoulder blades. As soon as I extinguished that, then it was good. And I found it on hundreds and hundreds of men and women since then. Now, these particular points I don't agree with all the way. I think a lot of these points are right on the rib costochondral joints, and you follow those down like this rather than straight down. And there are points in every one, even though they're not listed here. Okay, so I do not agree with where all these points are. So follow the costochondral joints on these. You're going to get a lot better reactions. Ipsilateral knee pain. So you go basically to the kneecap on the outer part, and you go up just above it, and there's a nodule there. You get a lot of people with knee pain that aren't responding. You go over that and you rub it with your thumb, and they will say, oh, that really hurts, and it's going through their whole knee. And that is very, very good for whole knee pain. Contralateral knee pain. You would stimulate not only this point in the eye of the knee, but right here in the opposite eye of the knee. It's an unlisted point for opposite knee pain. Now, I mentioned the woman that worked for me, and she had swollen knee on one side, could barely bend at 90 degrees, and I stimulated these points, and several seconds later all the pain in the opposite side was gone. She could fully bend her knee. So this works like a miracle in those cases. Stomach 36, eye pain, digestive disorders. This is the most mentioned point in the Yellow Emperor's Classic of acupuncture. It's called muddy waters of the stomach. It's also an antibiotic point. Somebody who has repeated infections throughout the whole body, stimulate that point. If you're going through and you have somebody that has everything wrong with them, it's another one that you can stimulate also, stomach 36. Pes planus and cavus. Go down through here and right in this area you can stick a needle in it. I like to take my thumb tips and scrape the tibialis anticus away from the tibia, and this will immediately have an effect on pes planus or cavus right through that whole area. Energy point. You go right in the joint between the distal tibia and fibula, and that will immediately help somebody's energy. Okay? If you go just below that right here, and it's not listed on here, stabilization point. So you go just under that, maybe a ½ inch, and it will, somebody who's clumsy has trouble with balance, that point right there, it's not listed on this, will help with that. You can stick a needle in it, you can stick your thumbnail in it, you can use a prod and stick it in there. Any of those work. In this area in here, you have tooth and gum pain, which we mentioned. If somebody has tooth and gum pain, and we're going to see something else on it here coming up, you go to the interosseous between the first and second and third toe, and you take the most sensitive spot. You have the person do whatever's causing the gum or tooth pain, and maybe drinking something cold, putting their teeth on ice, drinking something hot, just merely clenching, and you have them get in that position that aggravates it. You press firmly, lightly but firmly, on that most sensitive spot. Usually within seconds that pain will go away in the gum, normally on the ipsilateral side. I had a doctor go home after that, and he said that he had an issue with an infected tooth, and he did that and it cleared up the infection. So that's something I hadn't realized before then. So sometimes you can get an infection in a tooth clear up as well. And it just makes sense because you're affecting the nerve, you're affecting the lymphatic drainage and the circulation to and from the area. So to me it just makes sense. Here's the spleen meridian. I think from a front to back aspect, this makes more sense than any chart I've seen from the side. Again, but I would put it even higher up. I would put it up in here. I don't think this is representative. You got to go up between about the 5th and 6th rib, right up in here, just in front of the lat muscle. That will get rid of pain anywhere in the shoulder. You palpate the whole shoulder beforehand. Any muscle that attaches basically to the scapula. And the opposite groin, you press there, and that will be hurting simultaneously. Well, you hold a light but firm pressure here till the pain goes away, which is usually a matter of seconds. You go back and you repalpate anything that attaches that shoulder blade and the opposite groin, and it's let up very quickly. Now here's forbidden to the needle in pregnancy. This is spleen 1 and 2. So unless the person is ready to deliver, stay away from these points because it could cause a miscarriage, plain and simple. And you never want to use a needle on it. I wouldn't use a needle on it in any occasion, but especially during pregnancy, except when they're ready to deliver. Here's a heart meridian. This is another point that's good for frozen shoulder. This is depression point, so anybody who has any type of depression, I don't like that point. And I found that taking my fingertips and scraping the inner part of the humerus all the way up and down the length of the humerus, it's usually always painful in those conditions. I mean, you do that and the person walks out of your office a completely different personality because it really helps the depression immediately. There's the insomnia point. We talked about heart 7, right in the crease of the wrist, just proximal to the pisiform. Here's the small intestine. This is shoulder pain, and basically lateral flexion of the neck. Somebody's having trouble with lateral flexion, this will help that. I would put it a little bit more proximal than that, basically right in the middle of the belly of the muscle. Here's the bladder meridian, arrhythmia points. So you're right in the tear duct here, and this is the supraoptic notch. This is about 1/3 of the way through the orbit of the eye right here. Okay, and I personally wouldn't use needles in these areas, even though they're not overtly forbidden in the needle, which surprised me. I still would not use them. Here's bladder 54. In some charts it shows bladder 40. I think this is a more accurate chart. Anyway, this is called middle of the man, and you have whole spine pain. I've had several people who had pain running all the way up and down the vertebra. You just have them lay prone. You bend the knee, you find that middle point, and it'll be sensitive, usually on both sides. You'll hold a light but firm pressure, and you just say, okay, tell me when you feel your spine starting to loosen up. And usually it's maybe 10-20 seconds, and then you say, tell me when all the pain's gone. Usually it's half a minute to 45 seconds and all the pain is gone when they have pain all the way up and down the spine. Whole calf pain, 55 right here. This is roughly about 1.5 inches, 1.75 inches below the crease of the knee. And you can needle there. I prefer digital pressure. And basically the whole calf is painful before you do this. It's like the whole calf is protecting this one point. Here's a forbidden to the needle point. TMJ pain right here, bladder 57, just below the bifurcation of the gastrocnemius. This is on ipsilateral TMJ pain. I like treating this when the patient is standing, and they have them get their TMJ in the position where it hurts, and you press in there. I like using both my thumbs because it's kind of a dense muscle. Usually you press lightly but firmly, and they go, oh my gosh, and that would hurt anybody. You go the other side, does that hurt? No, well, I guess it wouldn't hurt anybody. So you hold it, you say, tell me as you feel your jaw loosen up and when all the pain's gone, and that happens just literally within seconds. Bladder 58 here, and this is just below the lateral head of the gastrocnemius. This is good for sacroiliac pain on the ipsilateral side. So if you have somebody who has ipsilateral sacroiliac pain, usually I like doing this again when the patient is standing, and they've tried everything on it. You stand, and again you press in there. As you're holding it, you just say, okay, tell me when you feel the pain letting up, tell me when it's gone. Usually it's just a matter of less than 10 seconds. Here we have 62 migraine pains. This is basically in the middle of the belly of the abductor digiti minimi, and I usually like just pinching this one. Usually comes from wearing high heels, either in men or women. And you can get them out of high heels. It usually doesn't recur, but it's usually with high heels. Here's 37. You notice it's just inside the spine of the scapula, about the 4th rib level. Applies to any abdominal organs, and this will get the abdominal organ pain. Here's just outside the 7th thoracic spinous process. Either of these points, either one individually or together, will get rid of suboccipital pain or tension. And I like just holding the pressure on it with my thumb, and it will let up just immediately. You'll be surprised at how quickly that goes. Reflex sympathetic dystrophy, right by the 10th rib, right here. This is really good for that about anywhere in the body. Digital pressure or a needle. Always, when you're in this area, angle toward the vertebra. You don't want to cause a pneumothorax, and don't go very deep on it either. Maybe a quarter of an inch, and that's about it, if that far. Stomach issues and digestion. This is right at the tip of the spinous of L1 and 2, also S2 down in here, same type of deal. And somehow we didn't get that marked, but also S2, the same thing. Kidney meridian, arrhythmias. You go to the top of the xiphoid process, about halfway over. Digital pressure right here on both sides can take care of arrhythmias, irregular heartbeats, very, very quickly. Here's another forbidden to the needle point. Sharp longitudinal arch pain. So you got a pain in the arch right here. You go to kidney 3 right here. That'll take care of that. Now, tongue-in-cheek, I'm talking about kidney 5, inner lower extremity pain. So anywhere up the inside of the lower extremity, right through here, you take your thumbnail and you stick it in there just above the plateau of the calcaneus, and it could be anywhere in here, and that will take care of pain anywhere up the inner part of the thigh. One we didn't get in here is number 2 here, basically at the tarsometatarsal joint. This takes care of turning of the head, rotation of the neck, and pain in the neck on rotation. So you'd put a needle in there, or you'd just put merely pressure of the digit on there, and that will help with that condition. Here are some forbidden to the needle points. You go about halfway between right here, about a third of the way down that crease, there's an indent. You can actually stick your finger, tip of it right there. When you do that, you feel something go into your nose and over your whole head. This is an unlisted point. It's really good for certain migraines. So when you're having trouble with migraine headaches, not finding an answer, that's really good for that. Equilibrium point. This triple heater 21, have them open the mouth, stick your finger in there, and in the TMJ socket, and that's good for equilibrium. Anterior shoulder blade pain. It's right here on 15, triple heater 15. Stroke, contracture of the arm, stick a needle here. The arm is in contracture. This helps the arm to extend. Also, another point for that is right here, right at the junction, and this is an unnamed point, junction of the spine of the scapula and the inner border of the scapula right here. Stick a needle in there. That helps with arm contracture in stroke or cerebral palsy, either one. Tricep strength, 11 and 12. Cold hands, right up in this area. It could be 5 or 6. And I had a woman who was freezing in the middle of the summer. I think I told that story. And she had, her hands were freezing. She had mittens on, 110 degrees out. And so I found a point right here, just held it for several seconds and her hands warmed up. She didn't need them anymore. Brachial plexus issues could be right between the joints in here, any one of these going across. This is one where it especially happens. Burning pain in the upper body, right in this web, any of these webs, burning pain in the upper body, but especially this one. Here's the gallbladder meridian. There's another forbidden to the needle point. Here's the upper trapezius pain. Neck rotation, flexion, lateral flexion, extending because of the upper trapezius. You place your fingers here on the forehead and you slide up with a firm pressure and you say, tell me when it hurts, and they'll say right there. That's where you either hold the point or you stick a needle or you put a prod, and within seconds the upper trapezius pain or tension will let go. Here's another forbidden to the needle point. Here's a pinky toe pain point. Outer lower extremity pain. So basically on this, this isn't exactly where you want to go. You want to stick the thumbnail above the calcaneus and just feel for that pain and the most acute point, and they'll say, oh, right there, and you'll say, okay, tell me when the pain lets up on your outside of your leg, and it could go up into the hip like this also. So anywhere up that outside of the leg, but again, this is not an accurate point. It kind of floats anywhere on the upper surface of this area. Now, right in here, the 34 point, and again, this is gallbladder. This could basically help the any type of trick ankle type of pain right down through here. Could be any of these points. This one is a particularly good point for that. Liver meridian, liver 14. I don't particularly think this is great, the way that this or most of them look at where they are. The last intercostal joint, costochondral joint rather, is where the best point is for that, and that's way down in here. And you put a prod in for that number 14, and it takes any of the quadrant below that. So the navel up pain in that quadrant on either side. So on the right side it would be there, the left side would be in the same position, only on the opposite side. Here in 13, that would take care of groin pain on the ipsilateral side. Here's another forbidden to the needle. Dementias, memory, thoracic scoliosis. That would be in this area, and it's very good for that. But you would take it also with this point on the previous meridian for those particular conditions. Vessel of conception, 24. This is good for pelvic organ pain, genitals, urinary bladder, etc., etc. L5 disc, spondylosis type of issues, right here on 21. Head of the humerus, 20. Anterior shoulder muscles, 19 and 18. Here are a couple forbidden to the needle points. Heart type of issues right at the tip of the xiphoid, and that helps a lot of coccygeal pain also, by the way. Hernia type of pain, 9, 8 forbidden to the needle right at the navel. Energy points, 5, 4, 3, and you can include 2. Some of them say 2 through 4, some say 3 through 5. I would just needle all of them for energy. Bladder control is C, or number 3, and I like particularly tapping this point sharply 3 times. I find that works better than the needle or digital pressure. Cervical, thoracic, and lumbar pain could be in the 2 area. That would be in the pubic symphysis. And the pubic symphysis would also take care of both of the lower quadrant type of visceral pain issues. The upper pubic symphysis would be cervical, middle thoracic, lower lumbar. Voice or throat type of issues would be in the conception vessel 1 area here. This is particularly when the person has had constipation or diarrhea where they're bearing down a lot, and that's where this comes in real handy. Now we have the governing vessel, forbidden to the needle points here. Cure of 100 diseases. I do not like how this has it. The more accurate one would be here when the head is upright. The head is upright and then it would be straight up. So I don't like the position it is here. I think this is deceiving. 22 is glabellar fontanelle. This is the posterior occipital fontanelle. So those are forbidden to the needle, especially in children. This is forbidden to the needle, 24. Stroke or migraines, you would actually go through this to 28. 26 is not good for it. You would, when somebody is in the middle of a stroke or a migraine, you would hold the back of their head, turn your thumbnail on its side, stick it directly between the eye teeth right in here while holding the back of the head, and a person will come out of a seizure type of condition for the 28 directly behind that. And so that would be right here, the seizure point. So you don't needle that directly, you go through it here. And stroke and migraine, actually this is deceiving. This is going to be right up under the septum, right in this area. If you lightly hold your thumbnail right there, you will actually feel the sensation going to your nose and over your whole skull cap. And it's good for that particular type of condition there. Here we have again the forbidden to the needle, and that's because it would go directly into the brainstem if you sunk it in there too far. Bodily circulation, 14, 13. 14 is basically between C7 and T1. although the one lower than it could also have a similar effect. Neuralgias and paresthesias, hand, feet, or crown. Basically, it's about the fourth T4 area. Could be anywhere from T2 to T7. T4 is the most likely one. Here 11 and 12 is forbidden to the needle, as is 7. Now RSD, reflex sympathetic dystrophy, is right on the tip of T10. It's really good for that condition. Low back, there's not really a point listed here. It's on the second sacral tubercle. I just had to use that on somebody here this week. It's not really a listed point, but it works in certain cases. Usually though, the position is between the sacrum and the coccyx. So this position is a little bit off. It should actually be in the joint between the sacrum and the coccyx. I have the person get in the position where the low back is aggravated, and I just stick my thumbnail in there and hold it. Say, tell me when it starts to loosen up, tell me when the pain's gone. Works very, very quickly and is very efficient most of the time. Dementias, the first point on the governing vessel, which is the tip of the coccyx, is good for that. Referred muscle pain, basic and clinical findings. And basically this is talking about convergence, as we just discussed here. I think this is a really good thing to read through, so I'm including that in your notes. Because you really need to understand convergence and summation to be the best practitioner possible. Acupressure, acupuncture, meridian therapy, that is a basic thing. 9L2. Here's Turek's Orthopedics, 4th edition. We have iliotibial band contracture. If you notice, when it's in contracture, it pulls down on the ilium, which then pulls down on the quadratus lumborum and the transversus abdominis, and it mostly causes a scoliosis in the thoracic area. So especially in the thoracic area, somebody with scoliosis, you ask them which side hurts the worst in the middle back, and they tell you, and you just have them stand there and you scrape over the upper part of the fibular head here at the attachment, and it'll be very, very painful. And then you have them stretch it for about 20 seconds. You go back to it, get rid of the residual, and that pain or tension in the middle back will be gone. And that works a lot for people who don't have a scoliosis, who have that pain or tension in the middle back as well. 9L3. Here's COOP'S miracle points. Here's a master acupuncturist I admire very much, and occasionally when I run into troubles, can't figure out what to do, I go to here. And I would invite you to do the same. I'm just giving this to you for your enumeration. May or may not want to use them. 9M is in mother. Here's Felix Mann, Acupuncture Cure of Many Diseases. And here's some other tracers. Basically, it shows the liver as the metabolic center in acupuncture. Lungs, heart, kidney, large intestine, upper digestive tract. And it shows some tracing of some meridians. This, I think, is very important to explain things to a patient. And for the patient who takes more time than normal, you can point to this textbook. The improvement that's noticed does not follow a steady course. Most often there are various ups and downs during treatment. There's rarely an absolutely steady improvement. Nature does not know straight lines. Not infrequently there's a setback at some stage of the treatment. So, if somebody is getting kind of discouraged, point this out to them in this Master Acupuncturist textbook. 9N, quick references. This is the Atlas of Acupuncture, Felix Mann, rather large volume. Here's quick references on some command points, and here's another one. And again, this is just for your quick reference if you'd like to use it. 9N-1, Seminar of Acupuncture again. And this shows the arm, legs, yin yang, and what they are in the way of the 5 elements, and what meridian they are, etc., etc. And basically these are quick references if you ever need to use them that way. And I would just put them up on the wall so you can just go over and glance at them if you need to. 9O, Lou point. Dramatic response of illnesses of the spinal cord origin treated with small intestine 3 and the Lou point. And this gives some neurology behind it. The Lou point is right here, and I've used this point a lot in my career. Just go down to the ankle, the lateral malleolus. You go directly under it, you go about halfway up, and it's right there. Okay? Small intestine 3, it's basically in the meaty part of the side of the blade of the finger. And so those can get really good results at times, and other things aren't working. So I have that whole article there for your enumeration. It may work for you at certain points. 9P is in Paul, breech position. Bladder 67, I think is one of the best ways to take care of that. You have the patient get in a knee-chest position so that the baby basically is in anti-gravity position. Stimulate that point at the little toenail area, and the baby will turn just very quickly. Okay? It's a quick way to do that. 9Q, holographic acupuncture. A guide for self-care acupressure with holograms. And I printed this whole thing out. So there's the table of contents and different types of issues. And what is holographic technology? Holograms are quarter-sized discs that can be programmed with electromagnetic frequencies. And you may want to do this. You may want to get into that. I'm presenting you this, the whole document. And if you would like to use that, there's the information. I personally don't use it that much. On occasion I do. 9T, head zones. Their relation to diagnostically relevant acupuncture points. You notice this is 2011. In the 1890s, Sir Henry Head discovered certain areas of the skin that developed tenderness or allodynia in the course of visceral disease, so viscerosomatic type of conditions. These areas were later termed head zones. In addition, he also emphasized the existence of specific points within these zones that he called maximum points, a finding that seems to be almost forgotten today. We hypothesized that 2 important groups of acupuncture points, the diagnostically relevant Mu and Shu points, spatially and functionally coincide with these maximum points to a large extent. And a comparison ahead papers with the Huang Di Nijing, or the Yellow Thearch's Interclassic, and the Zen Zhujia Zhijing Systematic Classic of Acupuncture and Moxibustion to the oldest still extant Chinese sources on acupuncture reveal astonishing parallels. So basically, these things keep being rediscovered over and over. And so just give credit where credit's due. He found them, but they actually correlate with things that were found anciently also. So give credit to where credit's due. 9U, experiments on pain referred from deep somatic tissues. And this by Feinstein. Pain provoked by the irritation of tissues deep to the skin has a characteristic quality that tends to be diffusely referred. Unlike acute pain from the skin, it persists for a considerable period of time. It's rather slowly transmitted to the consciousness. It is often associated with autonomic or other reflex concomitants such as bradycardia, fallen blood pressure, nausea, skeletal muscle spasm, etc., etc. Although the radiating nature of deep pain has always been theoretical and clinical interest, it has been experimentally investigated in muscle only since Lewis and Kellgren used the method of injecting hypertonic saline. Kellgren mapped the segmental areas of deep pain and tenderness below the fourth cervical vertebra by systematically stimulating the interspinous ligaments of 3 subjects. This technique was used by Campbell and Parsons to produce referred pain from the upper cervical somites. Inman and Saunders studied the relation of experimentally induced pain to clinical problems of deep pain and introduced the concept of sclerotomes. And so basically what I want to point out is these vary from person to person. But as I pointed out, scraping the bone and the interspinous ligaments and etc., where you can access it just under the skin, can have tremendous benefit. And looking at the areas where you have viscerosomatic response and prodding or needling, those referral areas can greatly help the circulation down to the organs, which we talked earlier about from the viewpoint of Dorland's Medical Dictionary. And so you can help the body correct a number of things in that fashion. And there's that whole document for your perusal. Just backs up what we were talking about before. 9V. Okay, fibromyalgia basically had been looked at for some time before 2010 as 11 of 13 or 11 of 18 points being hypersensitive, you could get a diagnosis of fibromyalgia. There have been studies that suggest the feasibility of using something as simple as assessing the pain threshold during the taking of blood pressure with a sphygmomanometer cuff, or the more sophisticated computerized cuff pressure algometry, as described by Jess Pearson and colleagues. Harden and others have reported that 3 tender points provide as much classification accuracy as the use of all 18 points. Basically, there's a lot of disagreement, and you can use one, you can use the other. What I have presented you with in this course are things that I find work very, very well, very quickly, 95 to 98% of the time, and you bypass having to use all of what others have used for a long period of time, and gets very, very complex. And I'm just saying you don't really need to get very complex most of the time. I'm not saying you never do. I use the very complex things, and I had the largest practice not only in the Midwest twice, but in the world. I averaged 640 new patient calls a month for a long time. And in 2001, when most patients' volumes went down by 30 to 50%, some as much as 70%, my volume went up 1,700% and stayed there for years. And the only way you can do that is to get great results and be very accurate and very quick. This ends Ttaps Part 5.